Bismillah ar-Rahman ar-Rahim. Dear students, our lecture today would be about liver transplantation. The objectives of this lecture is to know the evolution and milestones in liver transplantation, what are the indications of liver transplantation, and absolute and relative contraindications of liver transplantation. We also will review briefly liver allograft types used in transplantation, the immune suppression drugs used in transplantation, and complications after liver transplantation, whether medical or technical complications. Liver transplantation started in 1963 by the first liver transplant done by Professor Thomas Starzl in Denver, Colorado, in United States. However, the first 5 cases were unsuccessful. So Professor Starzl studied the causes of failure of these initial 5 cases and found that infection, rejection, and technical techniques were the main reason for his failure. So in 1967, he performed the first successful human liver transplantation reported using a cocktail of immunosuppressive drugs using immunosuppressive steroids, azathioprine, and anti-thymocyte globulin. This was the first human liver transplant successfully done. In 1978, Starzl also introduced a potent immune suppressive drugs called cyclosporin A in clinical use with a very good 1-year survivor after liver transplantation, around 70%, which was a breakthrough in the history of liver transplantation. Accordingly, the American Association of Study of Liver Disease issued a recommendation that liver transplantation is the most cost-effective modality of treatment for patients with end-stage liver disease. In 1984, Henry Bismuth introduced technical improvement by reducing the size of liver transplantation to adapt for young adults. And in 1987, the Wisconsin solution for preservation of solid organs was successfully reported. And in 1988, also Henry Bismuth introduced a technique for splitting the cadaveric graft into 2 loops, into 2 grafts, left and right, where the right is used for adults and the left loop used for children or small adults. Moreover, in 1988, Raya in Rio de Janeiro, Brazil, reported the first live donor liver transplantation when he performed liver transplantation left lateral segment from a mother to her 15 months old son. And in 1989, also Professor Thomas Starzl introduced a new, more potent, with less side effects, immune suppressive drug called tacrolimus into solid organ liver transplantation in the liver and kidney as well. And in 1993, Tanaka and Makoshi from Japan innovated the left loop adult to adult live donor liver transplantation. That was a breakthrough in performing and establishing live donor liver transplantation. However, in United States, they introduced the right loop, using the right loop instead of the left loop, and it was a breakthrough in liver transplantation. In 2001, Sun Lee from South Korea introduces the technique of using dual right and left loop transplantation from live donor liver transplant donor. What are the indications for liver transplantation? These mainly in fulminant liver failure, in decompensated liver cirrhosis, in hepatocellular carcinoma. Other non-hepatic indications, like when the liver is involved in metabolic disease affecting the liver, like familial amyloidosis or primary oxaluria, or due to impaired quality of life without decompensated liver, as it happens usually in cholestatic liver disease, where patients suffer from intractable pruritus, recurrent cholangitis, or severe osteoporosis without obvious clinical manifestations of decompensation. So in this case, liver transplant would be justified only for relief of such devastating symptoms. Now, let us discuss briefly the fulminant liver failure. It is usually occur on top of a previously normal liver, characterized by jaundice, coagulopathy, and development of hepatic encephalopathy within 12 weeks of liver insult. The transplant-free survival is poor, around 45 to 56%, and post-transplant survival for those who performed liver transplantation is almost 88 to 96%. Fulminant liver failure accounts for only 5% of all liver transplants. Causes of fulminant liver failure, usually drugs, the most common of which is acetaminophen or paracetamol overdosage, sometimes antibiotics or non-steroidal anti-inflammatory drugs. However, hepatotropic viruses like hepatitis A or acute hepatitis A and acute hepatitis B, and recently hepatitis E as well, acute severe form, can result in fulminant liver failure. Non-hepatotropic viruses like herpes simplex, CMV, Epstein-Barr virus, or autoimmune hepatitis, metabolic liver disease, especially fulminant Wilson, are among the commonest causes of fulminant liver failure. We have also vascular causes like development of Budd-Chiari syndrome or veno-occlusive disease due to hypercoagulable states, infiltrative liver disease due to heavy metastatic malignancy of the liver, or lymphomatous infiltration of the liver by malignant lymphocytes, or even infiltration of the liver by leukemia. Sometimes, rarely, amyloidosis can lead to fulminant liver failure. Also, acute severe alcoholic hepatitis can lead to fulminant liver failure. For those ingesting mushroom, sometimes contaminated with amanita poisoning, fungal infection, fungal exotoxin, can lead to fulminant liver failure. After exclusion of all these well-established causes, still unknown cause for development of fulminant liver failure in 10 to 20% of cases. These are the well-established King's College criteria for indication of liver transplant in fulminant liver failure. As you know, the most common cause of fulminant liver failure is the drug overdosage. We have two categories of drug, either acetaminophen or paracetamol overdosage, or non-acetaminophen drugs, or non-acetaminophen fulminant liver failure. In case of acetaminophen overdosage, hepatotoxicity, the indication for liver transplant would be arterial lactate level more than 3.5 millimole per liter after 4 hours of resuscitation, or arterial lactate of 3 millimole per liter after 12 hours of resuscitation, or if the patient presents with marked metabolic acidosis with pH less than 7.3. Among other indications, in acetaminophen overdosage toxicity, INR prolongation more than 6.5, or serum creatinine more than 3.5, or the development of hepatic encephalopathy stage 3 and 4. If the cause of fulminant liver failure is not due to acetaminophen overdosage, like in other indication like viral or autoimmune or reducing drug reaction. The indication for liver transplant are INR more than 6.5 or 3 of the following: if the age of the patient is less than 10 years or more than 40 years, if serum bilirubin more than 70.5 milligrams per deciliter, INR more than 3.5, persistence of jaundice, appearance of jaundice after 7 days of the initial insult. The etiology, if the etiology of fulminant liver failure is other than is due to viral, autoimmune, or idiosyncratic drug reaction. Now, in chronic liver disease, when should we do liver transplantation? It's usually only in cirrhotic patients with manifestation of decompensation. As you know, there is a strong correlation between stage of cirrhosis, clinical stage of cirrhosis, and 1-year mortality. So patients with liver cirrhosis who have no varices or ascites, the expected 1-year mortality is less than 1%, and appearance of varices only increase 1-year mortality to 3.4%. However, if the patient develops ascites, the 1-year mortality is reported to occur in 20% of patients. What's more, if the patient develops severe variceal bleeding, the mortality would increase significantly to 54%. So the clinical stages, according to clinical stages of cirrhosis, only patients with stage 3 and 4 have decompensated cirrhosis and should be listed for liver transplant. We have a semi-objective staging or classification of cirrhosis into compensated or decompensated according to 2 clinical parameters and 3 laboratory parameters. So if the patient has no ascites or hepatic encephalopathy with serum bilirubin less than 2 milligrams per deciliter and serum albumin more than 3.5 grams per deciliter, with prolongation of prothrombin time only 1 to 3 seconds above the normal value, in this case it's classified as a child A. Sorry, we give him he is reported as a child A. The total score would be about 5. We score the other patient if they develop ascites or hepatic encephalopathy stage 1 and 2, bilirubin from 2 to 3 milligram per deciliter, or albumin from 2.8 to 3.5 grams per deciliter, or prothrombin time prolongation for more than 4 to 6 seconds above the normal value. This is the second stage. The third one, if the patient has any of the following: moderate to severe ascites, stage 3 hepatic encephalopathy, bilirubin more than 3 milligrams per deciliter, albumin less than 2.8 grams per deciliter, or prolongation of prothrombin time for more than 6 seconds above the normal value. Now we come to scoring. If the score is 5 to 6, then the patient is a child BU class A. If the total score is 7 to 9, he is classified as a child BU class B. And if it is his score is 10 to 15, his child BU class would be class C. Only patients with a child BU B and C should be listed for liver transplantation, whereas patients with a child BU class A are absolutely contraindicated for liver transplantation. This MELD scoring, this is considered as a totally objective method for assessment of liver function, and they found a strong correlation between MELD scoring and the expected mortality of the patient. The MELD score stands for the Model for End-Stage Liver Disease, which is a scoring system used to assess the severity of chronic liver disease. And they found a strong correlation between the MELD score in predicting 3 months mortality in patients with decompensated cirrhosis. So MELD score 40 is associated with 100% mortality of the patient within 3 months. If the score is between 30 to 39, the mortality would be 83%. However, if the score is less, between 20 and 29, the 3 months mortality would be 76%. And those patients with a score between 10 and 90, the expected 3 months mortality is 27%. However, if the patient score is less than 10, the 3 months mortality is extremely low, almost 4%. In MELD scoring system, we use objectively 3 parameters, which is serum bilirubin in milligram per deciliter, serum creatinine, and INR, using a special logarithmic formula. And patients with MELD score equal to or more than 50 are considered for liver transplantation. MELD score determines priority for organ allocation. So if we have 2 patients, one with MELD score 20 and one with MELD score 30, who is going to do liver transplantation first? We are going to do liver transplant first for this patient with MELD score 30. Because the expected survival is much lower. There is another modification of MELD score using MELD sodium scoring system, which is even more effective to prioritize patients on the waiting list for liver transplantation. However, MELD exception points can be granted to patients in certain conditions. What are these MELD exception models points? MELD score exception points are offered to patients with hepatocellular carcinoma T2 stage within Milan criteria, patients with hepatopulmonary syndrome, patients with portopulmonary hypertension or familial amyloid polyneuropathy, patients with primary hyperoxaluria, cystic fibrosis, or recently performed liver transplant with technical problem in the hepatic artery resulting in hepatic artery thrombosis, or in patients with decompensated or even compensated cirrhosis but they suffer from refractory variceal bleeding, refractory ascites, or refractory hepatic encephalopathy. In decompensated cirrhosis, patients with decompensated cirrhosis are considered for liver transplantation only if they have stage 3 or 4 of clinical cirrhosis, that's say they have ascites or variceal bleeding, or those patients classified according to Child-Pugh B and C, or with scoring more than 7, or patients with MELD score more than 15. So patients with early cirrhosis like stage 1 and 2, that's to say no varices, no ascites, or patients with a Child-Pugh class A or MELD score less than 15 should not be listed for liver transplantation, with some exception as we have mentioned before. Now, looking for liver transplant for patients with hepatocellular carcinoma, we use Milan criteria for choosing proper patients with hepatocellular carcinoma for liver transplantation. The aim is to get survivor almost equivalent to those liver transplant recipients without hepatocellular carcinoma. So Milan criteria, if the patient has single tumor with maximum diameter not more than 5 centimeter, or 3 multifocal lesions, none of them more than 3 centimeters, in absence of microscopic vascular invasion or extrahepatic spread to lymph nodes or bone, this is considered a proper indication of hepatocellular carcinoma for liver transplant, with 5-year survival around 70%. The other criteria is UCSF criteria, which is considered as expanded Milan criteria where if the hepatoma size of the tumor less than 6.5 centimeter, or if the patient has 3 to 5 nodules with maximum diameter less than 4.5 centimeter and their maximum diameter totally is less than 8 centimeter, also in absence of distant metastasis or local infiltration or macrovascular infiltration, he should be considered for liver transplantation. Now come to contraindication to do liver transplantation. The first contraindication is HIV disease, in presence of HIV viremia, in presence of low CD4 less than 20, or clinical manifestation of HIV disease like diarrhea, malnutrition, generalized lymphadenopathy, and oropharyngeal monolysis. These are contraindication to do liver transplant in HIV patients. Patients who actively consume alcohol without or persistent to consume alcohol, they should be excluded from liver transplantation. Presence of extrahepatic malignancy, if the liver has a cholangiocarcinoma, if there is sepsis like pneumonia, if the patient suffer from advanced cardiopulmonary disease like chronic obstructive pulmonary disease or dilated cardiomyopathy. The relative contraindication to liver transplant depends on the center expertise and facilities at that medical center. So advanced age is considered is considered a relative contraindication. Some center take advanced age above, consider it if the patient above 65, where other centers consider advanced age only if the patient above 70 years old. Advanced cachexia, because the patient would suffer from early severe infection and the mortality is extremely high. Chronic renal failure, because the immune suppressive drugs are highly nephrotoxic. So in this case, we can do combined liver and kidney transplantation. Portal vein thrombosis, if you have a surgeon expert in doing thrombectomy, it will be no contraindication. History of rare cancer for solid malignancies, it should be no residual cancer or local metastasis since 7 years. If hematologic malignancy like leukemia, the patient should have no residual tumor for 10 years. Multi-system organ failures, those with cerebral error, stroke, and renal failure or respiratory failure should not be listed for liver transplant, or inadequate family or social support. What are the types of liver transplant? We can get the graft, the liver, from cadaver, from dead persons. We define brain death and we consider patients with brain death due to car accidents, severe laceration of the brain, or massive intracerebral hemorrhage. We can consider them for donation of their organs, and in this case we call it heart beating deceased liver donation, because it's performed in a theater while the patient is on the supportive system, ventilation and vasoconstrictor fluids and nutrition. Whereas non-heart beating, this is reported in China, where the hanged prisoners, after complete this, we get their organs. So we have two types of cadaveric organs, heart beating or non-heart beating. A split graft, due to shortage of organ pool, we can divide the liver into two anatomical loops, right and left, and give the right loop for adult patient and the left loop for pediatric or children or small adult patient. And this splitting process can occur in vivo or in vitro. Domino liver transplantation, it means that when we perform liver transplantation for patients suffering from metabolic liver disease like familial amyloid polyneuropathy, we will not discard their liver. We can give this affected liver to another patient with short term with expected survival less than 5 years, and in this way we can expand the organ pool. Auxiliary liver transplantation, it occurs only using small part of cadaveric liver, and this is used in fulminant liver failure. The aim of the auxiliary liver transplantation is to avoid the cost and the long-term side effect of using immunosuppressive drugs. Left donor liver transplantation, we can use the right lobe or left lobe or the left lateral segment, and the potential donor can be related or non-related. Related can be genetically related, like the son, the daughter, and the father, or genetically non-related, like the husband or wife. We can also use dual graft from live donors, from two live donors. We can take the left lobe from each one, or take the left lobe from one donor and the right lobe from the other, and in this way we can overcome the problem of a small for size graft and increase safety for the donor. This was an innovated technique by Lee in 2001. This is the whole cadaveric liver. This is split liver in vivo, and as you see we can split the liver into the right lobe and the left lobe. The right lobe including segment 5, 6, 7 and 8, where the left lobe includes segment 2, 3 and 4. This splitting in vivo. It can be also in vitro, that's to say on the pack table. After harvesting the graft, we can do it on the pack table, splitting it into the right and the left. This is live donor liver transplant. You can divide it medial to the middle hepatic veins into right lobe and left lobe. But for children and small babies, we can use the left lateral segment, including segment 2 and 3 only. Here is the donor right lobe. This is the donor. We take it from the donor on the left and put it on the recipient. This is the donor on the left, and this is the recipient on the right side. This is the scheme represents the major difference between orthotopic whole liver transplantation or live donor liver transplant using the right lobe. This is a schematic diagram represents the auxiliary liver transplant, where the native liver, here is the native liver, and this is the auxiliary liver, a small segment of left cadaveric lobe, and in this way we give the patient immune suppressive drug for 3 months or 4 months, after which we take biopsy from native liver. If there is complete regeneration of the hepatic parenchyma, we stop immune suppressive drugs, and in this way this auxiliary liver would be rejected and non-function. This is a dual graft using two live donor grafts. The using left lobe with left lobe from one donor, and and another left lobe from other donor, or using the right lobe from one donor with the left lobe from other live donor. This is what's called dual liver graft transplantation, which is a type of live donor liver transplantation. So what are the minimal listing criteria for liver transplantation? It means when should we refer a patient with cirrhosis to liver transplant? First, the child boo scoring should be more than 7, and the child boo class should be B and C. MELD score more than 15. The patient has a less than 90% of chance of surviving 1 year without liver transplantation, since in most centers the first year survival after liver transplantation is more than 90%. If the patient suffers from an episode of spontaneous bacterial peritonitis or refractory variceal bleeding or recurrent cholangitis more than 3 times per year as in patients with primary sclerosing cholangitis, or the onset of stage 2 hepatic encephalopathy in a patient with fulminant or acute liver failure. Improved post-liver transplant survival, the 1 year survival around 70 to 90% of cases, 5 years 80%, 10 year survival is 60%. Causes of improved survival after liver transplantation. This is due to appropriate time of reference for liver transplant, improved prevention and treatment of acute cellular rejection, better prevention and treatment of infection, and of course innovative and improved techniques for liver transplantation. What are the rationale for live donor liver transplantation? Why we should do live donor liver transplantation? This is because organ shortage. There is no sufficient cadaveric organs to cover all patients with end stage or liver disease or hepatocellular carcinoma. So we can get some live donor from the relatives of the patients. Unavailability of cadaveric organs in some countries like Egypt, there is no cadaveric organs at all. Donor safety and mortality in live donor is less than 0.5%, which makes this operation is very safe for the donor. The electively transplant patients before serious decompensation or death while on the waiting list for cadaveric liver transplantation. Patients on the waiting list for cadaveric liver transplant can range from 1 year to 2 years. So some patients deteriorate or die even before having liver transplantation. So live donor liver transplant would shortcome or would shorten the waiting list time, and so increase saving of these patients. Rare incidence of primary non-function graft. Primary non-function graft is reportedly more common in cadaveric liver rather than in live donor, because live donor organs are functioning very well and they are selected properly. Donor selection for who is the potential donor or the best donor for liver transplant. The age from 18 to sometimes 40 or 45 years. There is no comorbidity, of course. There is no diabetes or hypertension. If the donor is smoking or taking contraceptive pills, he should stop for 6 weeks before, or she should stop 6 weeks smoking or taking contraceptive before surgery. The body mass index around 25 to 30. The residual liver volume for the donor should be more than 30%, and for the recipient, the graft recipient weight ratio should be more than 0.8. Liver biopsy shows steatosis less than 20%. Why steatosis should be less than 20%? Because if steatosis is more than 20%, it would increase the cold ischemic reperfusion injury and the graft dysfunction. It would decrease the rate of hepatic regeneration in the donor itself, and increase mortality after major resection. Immune suppressive drugs used in liver transplantation. Of course, we have corticosteroids. They are used for the induction of immune suppression immediately after organ transplantation. In some patients or in some protocols, they use corticosteroids with tapering dose over 3 months. In patients, when the patient major indication is viral, like hepatitis B or C, we usually use steroid-free protocols. Also, corticosteroid can be given as boluses for the treatment of acute cellular rejection. Anti-metabolite immune suppressive drugs like Imuran, azathioprine, which is called Imuran, or MMF like Cellcept and Myfortic. Calcineurin inhibitors like cyclosporin A and which is called Neural, or tacrolimus, that's called Prograf. mTOR, mammalian target of organ rapamycin, like rapamycin and everolimus. Anti-lymphocyte agents like polyclonal antibody, anti-lymphocytic globulin or anticymic globulin, or monoclonal like Octa3, or anti-interleukin 2 receptor monoclonal antibody. We use the chimeric like basilixamab, or the humanized like daclizumab. These are the major drugs used as immune suppressive drugs in different immune suppressive protocols in liver transplantation. The steroids have a potent anti-inflammatory effect and used, as I mentioned, in liver transplantation to decrease the inflammation and decrease the cytokine release and prostaglandin. They decrease leukotrienes, they decrease nitric oxide production, and increase apoptosis or death of lymphocytes. The immunologic effect of calcineurin inhibitor like cyclosporin A and tacrolimus, they usually acting on T lymphocytes or B lymphocytes to decrease the transcription of interleukin 2, interleukin 3, interleukin 4, and tumor necrosis factor. In B lymphocytes, they inhibit its proliferation, and what's more, they induce apoptosis of B lymphocytes, so the memory cells are destroyed. And to ensure absence of delayed rejection, granulocyte, they decrease calcium-dependent exocytosis of serine esterases. The early medical complications after liver transplantation, we have graft dysfunction, primary non-function, ischemic reperfusion injury, small for size graft syndrome, acute cellular rejection, early post-operative infection, and drug toxicity. These are the major early medical complications after liver transplantation. Now come to graft dysfunction. Is defined by increase in jaundice, coagulopathy, and encephalopathy in the absence of vascular complications as the patient, and this may be due to ischemic reperfusion injury, a mild form of ischemic reperfusion injury, and in this case transaminases usually peak at 24 hours, then gradually decrease. Primary non-function graft is the most severe form of graft dysfunction, and the graft fails to recover after revascularization due to massive preservation injury to hepatocyte, due to severe form of ischemic reperfusion injury. Is present clinically with hemodynamic instability. The patient suffer from bouts of severe hypotension, high lactate, and hyperkalemia, prolongation of prothrombin time, progressive prolongation of prothrombin INR progressively increased. AST and ALT are usually in thousand, more than 2,000, 3,000, even 5,000 international unit per liters. And in this case, hepatic artery thrombosis should be excluded to differentiate it from primary non-function graft. It unfortunately occurs in 1 to 3%, but has a very high mortality rate. The ischemic reperfusion injury is less severe form of primary non-function graft. This ischemic reperfusion injury is severe, but graft recovers with oxygen supplementation, and the patient is susceptible to sepsis in this severe ischemic reperfusion injury. Elevation of transaminases is modest, between 300, 500, 700. However, there is coagulopathy, and the patient has delayed recovery from hepatic encephalopathy, or even develop stage 1 or 2 of hepatic encephalopathy. The other complication is small for size graft syndrome. This small for size graft syndrome is a clinical syndrome characterized by inability of a partial liver graft to sustain metabolic demands in the recipient. Clinical presentation or manifestation of a small for size graft: progressive hyperbilirubinemia, intractable ascites, prolonged INR more than 2 after the first 2 weeks of transplantation, frequent sepsis, patients suffer from encephalopathy with various degree, pre-renal failure due to intravascular volume depletion due to formation of ascites and effusion, pulmonary stress and infection resulting in respiratory distress syndrome. The patient may suffer from GI bleeding due to ischemic changes in the GI mucosa, leading to stress ulcers and gastrointestinal bleeding. What are the causes of small for size? Maybe small for size due to graft factors or recipient factors. Graft factor: if the graft size volume is small, that is to say the graft recipient weight ratio is less than 0.8, the old donor age more than 50, fatty liver status more than 20%. Recipient factors: high MELD score, high portal flow, insufficient outflow, that's to say in case of hepatic venous stenosis or outflow obstruction. Recipient factor: patients with high MELD score more than 30, they have high metabolic demands, they require high metabolic demand, so small grafts, if they cannot if they are not sufficient to meet these demands of the patient, then the patient condition would deteriorate and develop SFSS. Acute cellular rejection in liver transplantation is a common problem with a wide range from 17 to 40% after liver transplantation, and they manifest as mild graft dysfunction or really severe graft loss. If it is severe, rejection can lead to graft loss. Histological hallmark of acute cellular rejection is portal tract inflammation, bile duct damage, and endotheliitis. That's to say inflammation to the endothelial surface of the portal or terminal hepatic veins. Usually, liver biopsy is the gold standard for diagnosis of acute cellular rejection. Factors associated with acute cellular rejection: lower recipient age, creatinine level less than 2, fewer human leukocyte antigen DR matches, cold ischemic time more than 15 hours, donor age less than 30 years, cholestatic liver disease, primary biliary cirrhosis, and autoimmune hepatitis. Type of immune suppressive used: acute cellular rejection is more common in patients under cyclosporin A rather than tacrolimus. Retransplantation: patients who undergo liver retransplantation for the second or the third time have a higher incidence of acute cellular rejection. What about early postoperative infection? We have serious infection. The first one is the pneumonia. Pneumonia is the most frequent early postoperative infection, followed by cholangitis and sepsis. Gram-negative bacteria is the most common and rarely due to fungal infection. Pneumonia is associated with a serious complication after liver transplantation, including gastrointestinal bleeding, acute renal failure, acute respiratory distress syndrome, and high mortality. Predisposing factors for pneumonia are prolonged hospitalization prior to liver transplantation, mechanical ventilation before liver transplantation, Re-intubation after liver transplantation, drugs that can predispose to pneumonia, mainly the use of steroid boluses, octa-3, MMF, and immature immune suppressive drugs like everolimus can be precipitating factor for liver for pneumonia. The second sepsis is cholangitis. Acute cholangitis occurs less frequently now and is observed mainly in combination with bile duct complications, including anastomotic leakage, stenosis, or sphincter of OD dysfunction. Cholangitis can occur with acute rejection of various severity. Severe cholangitis should be treated to prevent potential life-threatening septicemia. CMV or viral infection, typically it occurs beyond the first month following liver transplantation. The most frequent viral infection is CMV, which can be asymptomatic or manifest as CMV disease with leukopenia, thrombocytopenia, or CMV hepatitis or pneumonitis. Following liver transplantation, untreated asymptomatic CMV infection might resolve spontaneously. CMV disease can be effectively treated with ganciclovir intravenous or oral recently introduced valganciclovir. Immune suppression related toxicity that the patient can suffer early after liver transplantation. Calcineurin inhibitor associated nephrotoxicity and neurotoxicity is well known and might occur if very early after liver transplantation. This toxicity is related to cyclosporin A and tacrolimus dose and the level, but is also associated with perioperative patient condition like hyponatremia resulting in what's called central bronchial myelinolysis, initial graft function, and the presence of complication like sepsis. In general, nephrotoxicity and neurotoxicity resolve after dose reduction or discontinuation of calcineurin inhibitor treatment. Conversion from tacrolimus to cyclosporin A and vice versa has also been reported to be effective. In severe toxicity early after transplantation, new immune suppressive agents including mycophenolate mofetil and everolimus are effective treatment options, either in combination with low-dose calcineurin inhibitors or in combination together. MMF and everolimus can cause hematologic side effects like leukopenia, thrombocytopenia, and anemia. MMF can cause diarrhea and abdominal pain. What are the long-term medical complications after liver transplantation? These are hypertension, especially with patients undergoing cyclosporin A immune suppressive drug, diabetes mellitus, mainly in patients who under tacrolimus treatment, dyslipidemia, mainly in patients with who are using emitters like everolimus or rabamune, and obesity is a well-known complication after liver transplantation. Renal dysfunction, it's been estimated that almost 20% of patients undergoing liver transplant would suffer chronic renal failure after 5 years from liver transplantation. Bone disease resulting in osteopenia, osteoporosis, or avascular necrosis of the neck of femur. Recurrence of primary disease, as we know, HCV viremia is universal after liver transplantation. Hepatitis B viral recurrence is prevented by using human hepatitis B immunoglobulin combined with nucleotide analogs. They are effective to prevent the recurrence of autoimmune diseases like autoimmune hepatitis, primary biliary cirrhosis. Steroid long-term use is mandatory in this category of patients. Malignancy, de novo malignancy has been reported in patients after liver transplant, including skin cancer like basal cell carcinoma and squamous cell carcinoma, melanoma, and oropharyngeal carcinoma like bronchogenic carcinoma and cancer esophagus have a higher incidence in patients with liver transplant than normal population. Really, PTLD or post-transplant lymphoproliferative disorders can develop after liver transplantation, which is usually due to a reactivation of Epstein-Barr virus infection. Usually, it is treated by 50% reduction of immune suppression can result in improvement or cure of the cases. If they are not responding to reduction of immune suppression, they can be given rituximab with or without cytotoxic drugs. The technical complications after liver transplantation, it is well known that internal hemorrhage after liver transplantation due to leakage from anastomosis of hepatic veins or portal veins, or bleeding from collaterals, retrocaval collaterals. Vascular complication like hepatic artery thrombosis and hepatic artery stenosis. Hepatic artery thrombosis occurs in 1.2 to 5% of cases. Portal vein thrombosis and stenosis, IV stenosis and kinking. Biliary complication like biliary leakage stricture and biliary infection like cholangitis. Non-specific surgical complication like wound infection, small bowel obstruction, and injury of intra-abdominal organs like splenic injury or splenic rupture. This shows hepatic artery thrombosis early after liver transplant that was managed by revascularization and exploration and revascularization. This showing portography showing anastomotic portal vein stenosis after live donor liver transplantation. Venocavogram showing kinking and obstruction of IVC, supradiaphragmatic IVC. This shows a T-tube biliary leakage with collection, what's called biloma at the anastomotic site. This MRCP shown anastomotic stricture between the donor and the recipient on the left side, and this is after ERCP on the right side. After doing ERCP and put stent, the obstruction is relieved. I'd like to thank you for your listening, and if you still have any questions or inquiries about liver transplantation, I would be pleased to meet you at internal medicine department at your convenient time. Thank you very much. Wishing you the best of luck.